Hello, ladies and gentlemen. Good evening. Let's enjoy the chest radiographs with Dr. Y, chest radiology. I'm Dr. Y, chest radiologist, medical professor working in South Korea. Today's topic will be lung cancer in general, session 13. Let's review the session 12 about the lobar atelectasis. Which lobe involved in atelectasis in this frontal radiograph? Yes, correct. It's right middle lobe. As I have told you before, right middle lobe collapse is not so fantastic, not so picturesque as other lobar collapses. As you see here, just irregular margined right heart border, maybe a slightly increased opacity at right heart area, and non-visualization of minor fissure. These three findings are usual manifestations of right middle lobe collapse. The fantastic triangular density in the lateral chest radiograph is not so often visualized. This is the common findings. Good job. Lung cancer. A. Cancer. Cancer is a disease in which cells in the body grow out of control. In other words, cells go crazy. B. Lung cancer. When cancer starts in the lung, it is called lung cancer. Lung cancer. A. Lung cancer is the leading #1 cause of cancer deaths all over the world. B. About 90% of lung cancers are caused by smoking. C. About 18,000 people in Korea, 76,000 in Japan, 127,000 in USA die every year due to lung cancer. D. About 50 people in Korea, 200 in Japan, and 350 in United States die every day because of lung cancer. Chest radiographic findings of lung cancer. They are usually divided by the location. First is central location. A. Obstructive pneumonitis or atelectasis. B. Fluid or mucous bronchogram. C. Mediastinal mass or like lymph node enlargement. D. Bronchial wall thickening. When they are in peripheral location, they usually showing the feature of a mass, usually more than 3 cm. B. Solitary pulmonary nodule, single pulmonary nodule, or we sometimes call them coin lesion, less than 3 cm. C. Ground glass opacity or ground glass nodule. D. Consolidation. C. Other findings, etc., such as mass with cavitation or apical mass. We call them superior sulcus tumor. This is the first case of central type lung cancer. We remember this patient. Yes, right upper lobe collapse due to proximal, right upper lobe proximal central lung cancer obstructing here, and distal collapse, right upper lobe collapse due to central large airway, right upper lobe bronchus lung cancer, showing obstructive pneumonitis. As this CT axial image shows, this is central type obstructive pneumonitis of right upper lobe, squamous cell carcinoma here. This is all squamous cell carcinoma at the proximal right upper lobe bronchus and showing Golden's S sign. This is second case of a central type lung cancer showing obstructive pneumonitis of left upper lobe. Also, we are familiar with this image. Loftus here, diffuse haziness here in the left upper lung zone, and elevated left hilum with increased density here. This axial contrast enhanced CT shows the mass here at the left upper lobe bronchus. This is the left main bronchus, and this S shape of collapse showing Golden's S sign, proximal mass and distal collapse. This low density here is bronchus filled with mucus or fluid, so we call them mucus bronchogram or fluid bronchogram. Squamous cell carcinoma. Another pattern of central type lung cancer, HILA lung cancer. This is also the central. We are familiar with this one. Hilum is not normal shape with increased opacity, with irregular margin and strict linear lines here. Yes, small cell lung cancer at left hilum with lymphangitic obstruction. This is coronal contrast enhanced CT. Central type, hilum, small cell lung cancer, conglomerated. Yes, this is left hilar mass invading pulmonary vessels, conglomerated with left side mediastinal lymph node. So altogether, this is small cell lung cancer conglomerated with lymph nodes in central portion. So central type pattern. And this is lymphangitic obstruction here. This is the same patient with axial lung setting CT. Right side bronchus is normal thickness, regular shape. The left side is irregularly thickened bronchial walls with this small cell lung cancer. It is clear, bronchial wall thickening finding is clear on the CT, but chest radiographs are not so clear usually. But we have seen some streaky lines on the frontal chest radiograph of this patient. That was bronchial wall thickening, actually tumor infiltration to the bronchovascular bundle. And also we call them lymphangitic obstruction. Let's move to the peripheral type lung cancer on the chest radiograph. What do we see? On the right upper lobe, there is a big, huge mass, more than 7 centimeters here. Yes, we call them mass when mass is more than 3 centimeters. Huge. Peripheral, more than 7 centimeters means T4 staging. Peripheral mass in right upper lobe. Let's look at the mass on the lateral filum. Where is it? As you know, this is minor fissure and major fissure. So this is upper lobe and the mass is here, mainly in the apical and posterior segment. Yes, huge mass in right upper lobe proven as adenocarcinoma. Another case of peripheral lung cancer here. What do we see? Yes, more than 3 centimeter mass here. What about the hilum? Hilar vessel, pulmonary arteries are not overlapped with the mass. So the mass is not in hilar location, maybe anterior or posterior to the hilum. Peripheral mass, peripheral type mass. And we also see 2 daughter nodules in the left middle lung zone. This is lung window setting axial CAT scan. The mass is here, right upper lobe, more than 4 centimeters and separated with hilum, not involving the hilum, not hilar lesion. So mass is peripheral type, mass, right upper lobe anterior segment, silhouette sign negative. What do we see here? Peripheral type, solitary pulmonary nodule, less than 3 centimeters. We see coin lesion on the left middle lung zone. Actually, we do not know whether it is upper lobe or lower lobe. This is coin lesion here, peripheral type. This is axial lung window setting CT. We see the coin lesion here, major fissure here, so it's in upper lobe location, 2 centimeters in length. This is SPN of left upper lobe, large cell neuroendocrine cell type tumor. Let's look at this frontal film. What do we see? And what do you see? Eureka? You find it? Not yet? Yes. Look at this area. Looking good, looking normal. How about the other side? Something hazy, something increased opacity. Yes, that's correct. Although it's not a coin lesion or solitary pulmonary nodule, but here is some increased opacity, unclear margin. Yes, that's the findings. We call it ground glass nodule or ground glass opacity. This is axial thin section, high resolution CT scan. What do we see? Yes, ground glass opacity or consolidation. Yes, anterior portion is pure ground glass opacity and posterior portion is solid density. So we call this as part solid ground glass nodule. Right upper lobe, posterior segment. This is peripheral type adenocarcinoma. Let's look at another type of peripheral type tumor. Consolidation, actual consolidation. Where is it? Yes, left lower lobe, because left heart border is clear, aorta line is obscured. That's left lower lobe consolidation. And some air bronchograms here and here. This is contrast-enhanced axial CT image. What do we see? Yes, consolidation with pulmonary vessels. In usual cases, we call this as lobar pneumonia, but this is not a lobar pneumonia. This is mucinous adenocarcinoma. Consolidation, left lower lobe. We used to call this as CT angiogram sign because the pulmonary vessels are more prominent than in the consolidation of pneumonia, because the background of consolidation alveolar space is filled with mucin, so darker than the X state of pneumonia. So the vessel is more prominent than in the pneumonia. But recently, we do not use that term. CT angiogram sign, just forget it. This is mucinous adenocarcinoma, famous for just looking like lobar pneumonia. What do we see here? Large mass or consolidation in left upper lobe with central cavitation. Yes, peripheral type tumor with cavitation. This is axial contrast enhanced CT of this patient. In left upper lobe, there is a large mass more than 5 centimeters with a thick irregular margined wall with large cavitation. This is the typical, usual shape findings of cavitary peripheral lung cancer, most likely squamous cell type. I used to call this area apex with the first lip. This lung area I used to say owl's eyes, bilateral owl's eyes. If the bilateral owl's eyes are not symmetric, not looking like eyes, that means something wrong here. That's here. Increased opacity and rib destruction. Yes, superior sulcus tumor. We used to call this as Pancoast tumor as the name of Dr. Pancoast, but we do not use Pancoast tumor anymore. Just superior sulcus tumor is better. What do you find in the left side film? This film is several months before the patient. Do you find what's wrong? I just told you the owl's eyes. Is right owl's eye okay? What about left owl's eye? Left side looks okay. Something increased here. Superior sulcus tumor is very important because, as you see here, it is very, very hard to find out what's wrong here. We used to miss, not easy to find out the lesion pathology. That's why superior sulcus tumor and the owl's eye should be memorized. We just finished the introduction of lung cancer findings on chest radiographs, chest CT. Lung cancer is the leading cause of cancer deaths and very, very important in daily practices. So please remember the findings here, which I have shown to you. And the next several sessions will be also about lung cancer. Lung cancer is so important. Let's move on. Answer for the quiz of last session. You got it? Bingo. Asbestos-related pleural plaque. Does these calcifications look like holly leaf? We call this as holly leaf sign. And diaphragmatic pleural calcifications, also we see here, sometimes told as pathognomonic for the asbestos-related pleural plaque. This is the quiz for the next session. What are these? Where are they? What caused this kind of calcifications? I think you know the importance of lung cancer and smoking. And I also know the importance of lung cancer and smoking. But I'll tell you once again with emphasis, lung cancer is terrible disease. Don't smoke, just don't smoke. This was the comment by Yul Brynner on the free commercial when he was dying with lung cancer. He used to be a heavy chain smoker. Don't smoke, just don't smoke. Next sessions will be about the findings of specific pathologic lung cancer cell types. Like, subscribe will be a big support to me, Dr. Y, Chest Radiology. Thank you very much.